My name is Jen Katzman. I'm the Medicaid Deputy Director for Policy, Waiver, and Public Affairs, as Ruth indicated. And I'm pleased to be joined by 4 great panelists. Dr. Andrey Ostrovsky, the former Chief Medical Officer of the U.S. Medicaid Program and Managing Partner at Social Innovation Ventures. Dr. Earl Benjamin Robinson, the Deputy Director of Community Partnerships and Health Equity Leadership at the Louisiana Department of Health. Dr. Marcus Bachhuber, the Chief Medical Officer at Louisiana Medicaid. And Melinda Karp, the Senior Vice President of Consumer Partnerships at Commonwealth Care Alliance, who've all joined us today. Over the next 30 minutes, you will hear from these national experts, and I encourage you to use the Q&A function in Zoom if you have any specific questions for them. Now, jumping right in with the first question to our panelists, can you frame for me why member engagement is so critical? What does this mean when you consider disparities in access, information, and resources? And we'll start with you, Earl, and then move over to Marcus and then Melinda, please.
Could you kindly repeat the question again one more time? I'm sorry.
Not a problem. Can you frame for me why member engagement is so critical, and what does this mean when you consider disparities in access, information, and resources?
Gotcha. So when we look at healthcare, oftentimes people only think about it from the perspective of my patient comes in and they get their medication. But as it relates to disparities, I think it's very, very important that we expand the idea of healthcare and community engagement. Client engagement, patient engagement is a key way to help better meet the needs. One, understand the needs of the people that you're serving and thus meet their needs. And so given the disparities that we see happening inside, well, disparities to me mean, for the most part, that people are having different experiences. And those different experiences contribute to many of the disparities and health outcomes that we see happening. And so as a provider of healthcare, it's very, very important that while individuals are getting the care that they need, that those who are facilitating that care understand that people are having different experiences, and to better meet the needs of those people, the facilitator or the provider of that health service needs to understand that. And that information needs to be inform how one interacts, provides services to, and listen to the patients.
Thank you. Marcus?
Yeah, thank you, Jen, and thank you, Dr. Benjamin. I'd just like to echo a lot of what you said. I think you can't really disentangle healthcare, talking about healthcare effectiveness and disparities. They're very intertwined. I think, one thing I've learned as a physician is that you can't, access is important, but it's not sufficient. Information and education is important, but not sufficient. Really, you need all three. Patients need access to care. They need information, education. They need the resources to be able to act on the information that they receive. And so it really takes all those things. Not, each one is necessary, but not sufficient.
And Melinda, what are your thoughts?
Thanks. And yeah, just building on the comments that my colleagues have made so far, without really authentic engagement between those who are using healthcare services and those who are designing and implementing healthcare services, we really can't get to solutions that really work for folks. And the reality is, when I think about the expertise that we bring to the table to solve the issues that we have around healthcare, we have two kinds of expertise. We have the expertise that those of us actually sitting on the panel right now have, which is, we are experts by training. We've gone to school, we've had lots of different jobs. We may have some lived experience as well, but we're coming to the table as experts by training. The other kind of expertise is the expertise that our consumers, that our patients, our members bring to the table, and that is expertise by experience. And what without actually creating a partnership between those with lived experience and that set of expertise and those with expertise by training, we actually can't get to solutions that work. You know, consumers or patients or members, they don't think about their needs through the sort of functional or departmental lens of a government agency or a health plan or a provider. That's the way we as professionals might think about it, because that's the environment that we sit in every day. But they're thinking about their needs and engagement through the context of their own life, their own community, and the needs that they bring to the table. And when we think about when we think about it through our lens, we're really missing huge opportunities. We tend to think about, okay, what is it that that we want our members or our patients to know at this point in time, at this stage in our process? We need to flip that on its head and instead say, what does the member, the consumer, want and need to know at this stage of their journey? And without that fundamental shift, as I keep saying, it's really hard to get to solutions that are truly going to work and engage individuals and their communities to get the care and service that they need.
That's wonderful insight. And this obviously is a more pressing issue now, considering not only COVID-19, but how the pandemic has exposed such deep-rooted issues in our health disparities. More broadly, I'd like to ask, how has communication and engagement changed over the recent years, and what are the new methods for digital communication and the impact on with COVID-19? We'll quickly start with Dr. Benjamin again, but then go over to Andrey, and then lastly to Melinda.
So I think over the, a long time ago, I think what people did in sharing information, particular healthcare information, is they saw it as just general education, and it's just providing someone a pamphlet, and it's sending someone some mailing, and we missed opportunities there because we were not taking into consideration, one, how people learn, two, what's going on inside an individual's environment that may be a barrier to them being able to receive the information. And so over time, what we are seeing is healthcare providers, payers, paying a bit more attention, learning what's going on, what are the social determinants of the patient panel, of those patients, and using that information to better develop messaging, do what we're doing now, finding ways to better communicate with people. So I think over time, what we have seen happen is that we initially just thought about information sharing from the perspective of, I will just provide you some information and hopefully you will understand what it is that I have to say. But we are seeing over time, and that it's important that we really get to try to understand the nuances of the people that we're serving. And I think more healthcare providers and facility payers are doing that. And that's why I'm glad that we're having this conversation today, because I think initially what we saw happening was just general information was being shared. And so we are creating more, better ways of providing information to the people that we serve, because we're listening, we are listening better to them saying, hey, this is what I need, this is what's going on with me, these are the barriers that are keeping me from responding or communicating or being able to eat the message that you're providing to me.
Thank you. And Dr. Ostrovsky, what do you think about digital communication and the impact with COVID-19?
Well, the problems that technology companies have had before COVID-19 generally persist today. I think that solutions that are trying to improve communication, engagement solutions have fallen into a bit of a gap before COVID, and that gap has persisted since COVID. And the gap is generally one where service businesses have a way to generate revenue, right? They bill for CPT codes, HCPCS codes. Pure technology plays that are focused on back-end processes like revenue cycle management, they have a means for getting in either with payers or in some cases with states through MMIS systems. But solutions that are focused on engagement fall into this chasm somewhat where there often isn't a discrete bucket or budget, I should say, to pay for those solutions. And that was certainly the case before COVID. And then when COVID hit, there was an enormous flexibility introduced across pretty much every state and territory in terms of payment for technology. And so the technology-enabled services had this proliferation. Telehealth, we've seen, had massive proliferation. Solutions on the pure back-end, business process as a service, pure tech plays, they haven't really seen much of a change. I mean, they still have a place to sell into, although obviously state budgets are kind of compromised because of COVID-induced economic hardships. But engagement and communication platforms, they've kind of been left out from this momentum that's been built in increasing payment flexibilities for telehealth. And so, unfortunately, it's still an uphill battle for solutions trying to improve engagement, trying to improve communication. And in the end, it's, I think it will continue to be a challenge. And I'm glad that your state is focusing on trying to mitigate that challenge.
Thank you. Melinda, what do you think about changes over recent years in communication?
So, you know, I agree with both Earl and Andrey in terms of where we've been and where we are now, and that we, you know, organizations are looking more closely at how they're messaging and really thinking about that community and that individual context more when they're thinking about how to do communications. I think, you know, from a health plan perspective, you know, COVID has really forced prioritization and decision-making in this space like we've not seen before. And to Andrey's point, while much of that has been focused initially on telehealth specifically, I actually think a lot of the thinking that's going on in organizations that was first devoted to telehealth actually spills quite nicely over into the broader communication and engagement space. Telehealth is just one use case for, I think, very similar kinds of tools and approaches. And so the crisis has really forced organizations, my own included, into this really rapid cycle sort of test and refine approach and taken us out of our comfort zone. I mean, the reality is, you know, we used to spend months and months and months and months debating these kinds of technologies and solutions, and then, to be totally transparent, not necessarily taking any action on them, to Andrey's point, because there wasn't necessarily a budget to be able to fund some of this stuff. But I think that because of COVID, we were out of our comfort zones, and we were thinking very differently about it and thinking much more broadly about how to apply some of the solutions we've created to create telehealth within our organizations. On the consumer side, on the patient side, you know, we've seen really increased receptivity to tech solutions related to communication. I think the common myth, and I really think it's a myth, is that individuals who have complex health and social needs have a whole variety of barriers, and they don't want to and can't engage with these sorts of tech solutions. And that's just plain wrong. I think, you know, individuals with complex health and social needs are no different than anyone else in terms of their willingness and interest in trying new things, especially if it makes their life easier. I think the challenges remain around for this population to be thinking about accessibility and usability and really ensuring learning and understanding. And those things haven't changed. You know, those things were there 3 or 4 years ago, and they're there right now. That just because we have a tech solution doesn't mean that it actually works for folks. And that's the place where we really need that continued partnership between the end user and the organizations that are putting these kinds of technologies out there to really make sure that we're creating solutions that work for folks. Because having the tech solution is only one part of the stool.
Thanks, Melinda. Let's dig a bit into the question of the digital divide and access. Digital access is a persistent and important consideration, especially when talking about Medicaid. 71% of the bottom third income earners in the country have smartphone access versus 97% of the top third. 56% of the bottom third income earners have home broadband, while 94% of the top third do. These gaps are closing, but are important in looking at solutions as we talk through our proposals and vendors today. Can you speak to disparities in the U.S. and nationally? We'll start with Dr. Ostrovsky again, and then over to Dr. Benjamin. So why don't you kick us off, Andrey?
Sure, you bet. I think maybe I'll add to the statistics that you just mentioned. I had my research team did a recent analysis that was funded by the California Healthcare Foundation, and the analysis was largely focused on duals, so it's a little different scope than pure Medicaid. But something that was interesting is that if you think about the solution providers out there that are targeting, if you ask the question of who is the primary financial customer and who is the primary end user, what's interesting is that 64% of the companies surveyed had the consumer as the target end user of a given technology. And given the stats you just described, there's somewhat of a disconnect between all these companies targeting the consumer when the consumer not only doesn't have purchasing power, which is a separate issue, maybe that they're able to interact with the technology but not necessarily pay. But what if they don't have Wi-Fi? Or what if they don't have a smartphone? Or many of them do, but then there's the data plan issue. And actually it's the data plan issue that becomes the real challenge, especially when there's any kind of video interaction. And so I think, as with many things in healthcare, the fix to health equity issues is not a health intervention. It has to do with broadband investment, rural broadband investment, and making sure that there's consistent access to both the connectivity like Wi-Fi, but also the hardware. And that is often out of scope for what Medicaid can pay for. Sometimes you can get creative, obviously. And I think that the solutions aren't necessarily at the level of technology innovators. I think the solutions are at the level of probably what your colleagues are doing in the legislature right now, right? Trying to figure out, okay, what are we gonna do with this budget, and which pools of funding and which programs can we weave together and have braided funding such that the health and the housing and the communication and the transportation, all of those come together to some common end goal that's an equitable future state of health. Since we are focused on tech specifically, I think the main implication of that gap and that divide, which will persist, and it may very well probably will get worse, again, given the economic circumstances and the state budget shortfalls, I think it's incumbent on investors to be aware and then to be supportive of their entrepreneurs that are trying to take a more long-term view in their investments, so that they're not just trying to squeeze out short-term gains and short-term M&A activity, but rather are looking more long-term and willing to have product roadmaps view more long-term with an eye towards equity and access, so that these innovations can continue to target Medicaid populations and not be forced to go to commercial or employer or direct to consumer, which unfortunately happens a lot and kind of, again, bypasses the Medicaid population and widens that gap.
Mm-hmm. And so, Dr. Benjamin, given the statistics I read earlier on the gaps between the bottom third and top third income earners and their use of smartphones and internet, though those gaps are closing, it's important to look at solutions. Can you speak to the disparities in the U.S. and nationally as well?
Yeah, I think, the attention to detail that you're using to describe the disparities is important, because I think to counter that in building and trying to mitigate the disparities that we see happening, and in trying to prepare people for the changes that are coming, and in an effort to communicate and be engaged with the patients that one is seeing, we really have to be very, very intentional. Earlier, Melinda talked at length about a number of things, but I think what stood out to me and what she was saying was there needs to be an intentionality in trying to engage with people. I know inside the state of Louisiana, and especially in rural settings, there are tremendous broadband issues. I know that Louisiana is not the only state that has those issues. And so that would be something that has to be thought about when trying to develop a community engagement plan for the people that we're serving. Having those discussions up front and trying to develop strategies to mitigate that, I think is something that should be happening across the board. I also think that if you are truly and honestly wanting to wanting to be engaged with people, you have to be just as intentional as you are with doing those quality measures that are provided inside, those standards that are provided inside your organization. You have to get down to the nitty-gritty. You need to understand the nuances of the communities and the people that you serve, and use that information to develop and map out engagement efforts that meet the needs of people. It can't be, we're going to use texting, and you haven't done the homework of, are people in this area going to use texting? Or do people in this area understand the importance of texting? Culturally, is texting something that's significant to this population? And so having those very intentional and earnest conversations about what the gaps are, having those very earnest and intentional conversations about where those broadband issues are, and also having those very earnest and intentional conversations about that this may not be a priority to the people that we're serving, but that doesn't mean that we don't do our best to try to find out how do we mitigate that, how do we overcome that. One thing that I've heard people say sometimes, if you build it, they will come. That's not necessarily true when you haven't done your homework about what would make an individual come and utilize the service. What are the barriers that are keeping an individual from participating in this care, despite the fact that they know that they need this health care, despite the fact that they know that this could be beneficial to them. There may be other mitigating factors that keep them from being engaged. And so as a healthcare entity, it's on the onus of that entity to really do its due diligence in finding out what those social determinants are and using that information to build effective and robust community engagement efforts that are in alignment, are at the same standard of those quality improvement standards or implementations that are taking place.
Great, thank you both. Now let's pivot and let's talk about the current gaps in access to information and communication and what the needs are a bit around the solutions we'll be hearing from in just a matter of moments. What do you think is needed, broadly speaking, both here in Louisiana and nationally? We'll start quickly with you, Marcus, and then over to Melinda, and lastly over to Andrey.
Thanks, Jen. I would say, with any kind of communication, there's some general things, general issues you want to make sure you're taking care of, like language accessibility, writing it or communicating in a way that's readable and understandable for folks with all different English proficiencies. Just that general stuff, which historically state Medicaid agencies have paid attention to. Then I think there's the unique things about the members that we serve. The first one I would say in Louisiana is really mobility. So people just kind of in general move around a lot more now than they did in 1965 when the program was created. People rely on technology a lot more now than they did before. Cell phones, texting, email. A lot of communication isn't by letter, isn't in writing, on a piece of paper anymore. And so trying to figure out how we as a state agency can fit into that to best serve the members, I think is a challenge, nationally. I think in Louisiana also we have a lot of people that have Medicaid because they have seasonal work or they're in the hospitality industry, and they may be, they may have Medicaid insurance for a brief period of time, and periodically throughout their life, and kind of orienting them or educating them on how things work, I think may prove a challenge for some people. And then I think there's going to be a diversity of preferences among members. So we have about 1.7 million, 1.6, 1.7 million members, and clearly they're not all going to want the same form of communication the same way. I mean, you ask 3 people what they want for dinner and they'll give you different answers. So 1.6 million, there's going to be a lot of variation there. So, trying to figure out how we decide or how we determine what works best for who, what works, and how best to engage with folks in a way that they want to be engaged with, I think is the big issue.
Absolutely, I think you're spot on. What do you think, Melinda, about what's needed here in Louisiana and nationally?
Yeah, I mean, I think it comes back to, and Earl has said this has been a theme in our conversation this morning already. It comes down to, first and foremost, listening and understanding. As Marcus said, there isn't a one size fits all solution. And we really need to understand down to the individual member level, what kinds of communication vehicles are going to work for them, and what are their preferences? How do they want to hear these communications? And until we can really figure out how to do that at an individual person level, and then create solutions that that actually meet those different needs, it's going to be hard to make a dent into those 1.6 or 1.7 million folks in Louisiana and nationally as well. And as I said before, it comes down to accessibility, which is not just, the broadband issues and the pure technology issues are super important, and a bar that we can't do anything else till we cross that bar. But even once we've crossed over that hurdle, accessibility means lots of different things to different individuals depending on the challenges that they're coming to the table with. And so we really need to understand accessibility beyond, like, okay, they have broadband now, and even we gave them a device, so they should be all set. There's accessibility in terms of what those communications need to look like and how they need to flow to meet individual needs. And then there's really finally learning and understanding. And that's, again, where we have to start with listening, because we need to understand, we tend to focus on, these are our messages that we need people to understand so we can educate them and they can learn. We really have to flip that over and think about, what are the needs that these individuals have every day, and how do we fit our messaging into the context of the needs that they already have? Because that's the only way this kind of engagement can have priority for folks, is when it fits into the needs that they themselves have and the experiences that they're having every day. We hear it on the provider side all the time. Well, if you can't fit this into my workflow, then I'm not going to be able to pay any attention to this. Well, it's kind of the same on the member side, only their workflow is sort of the life they lead every day, and we have to figure out how to fit it in there.
That's a really good point. Dr. Ostrovsky, what do you think about what's needed both here in state and nationally from the communications front?
Well, you start with good leadership, and you got a good one there, so good job. I would say that there's a couple of things. One is building on some of the work adaptation has done, and like really going to the ground and understanding, empathizing with the consumers and the beneficiaries. I think taking some of those design principles and applying them to how enrollment policies and processes exist. For example, if someone is going to apply for SNAP benefits, or if someone is going to apply for some kind of other benefit, making a really seamless experience where an individual that has low economic status and eligible for multiple types of services, to make those services really easily available to enroll in, even though they may not realize that they may be eligible for other types of benefits. Related to that theme of introducing and weaving in service design into how policy is made, I think that having a continuous assessment and visualization of the journey of consumers on their way to Medicaid eligibility. I'm sure in Louisiana, actually I know in Louisiana and almost every other state as well, the number of Medicaid beneficiaries is going up, and it will continue to go up for some time. And so how can we anticipate when and who are the types of folks that will soon become Medicaid eligible, and can we actually stave that off? Are there mechanisms we can put in place to ensure that they actually don't spend down their savings? Can we get them into employment productively while making sure they have access to health insurance? And then at a little bit more of a macro level, I think that building on the innovative spirit that you all are already focusing on, continuing to really invest in bringing in talent into the state Medicaid program that otherwise might not think to go and spend a tour of duty with the state Medicaid program. I know at the federal level, we had the United States Digital Service. I know Louisiana, I think you guys have engaged with 18F and other such consultancies, but building out a cadre of folks that otherwise would be Google bound or Facebook bound, or maybe even working with some of the companies that'll be presenting today, and create a program where for 2 to 4 years they do a stint with you all. I think that'll that could really introduce a level of consumer centrism and product thinking that could be really interesting for communication and engagement. And then finally, I think if there was a way to make it easier for solution providers to actually contract directly with the state Medicaid program, and I think the best conduit, frankly, is if they were to be viewed as modules, as I alluded to earlier, as part of the state MMIS system, and creating an agile procurement pathway where it's not like one massive contract for Xerox for 30 years or whatever. It's let's do a 6-month stint where it's a small procurement. If they do great, show that you're awesome, and then you get another 1-year re-up. And there's precedent for that. We've done that at the federal level. Some states have attempted to do that as well. So any one of those things I think could be productive.
Really interesting, yeah. And so, I'm just checking the time. It looks like we have about 10 more minutes, and we're right at our last question. So I guess what's next? What do you think are the unaddressed issues in member communication and engagement that we still need to talk about and address today? We'll start with Melinda and then finish up and wrap up with Dr. Ostrovsky again. Oops.
Sorry about that. We've covered so much that I think, what's left to cover in the time that we have. I mean, I think we've really moved from the macro and thinking about how do we always think about the end user, the member, the consumer at the center and as a partner in development and design and evaluation, through to Andrey's had some great suggestions for how the Louisiana, state Medicaid specifically can make some changes to accelerate progress and the ability to bring valuable technologies to the table. I think if there's one gap that I think we still need to think about, and Andrey started down the path of, forget about these really long contracts, let's think about 6-month contracts. Piece that I would really echo in saying we need to move to a place, in state government and even in, private settings caring for individuals and populations with complex health and social needs. We need to move into a process where we are much more sort of in rapid cycle, testing, implementation, and refinement. And the more we can get comfortable doing that, and that takes folks in healthcare way out of their comfort zone, the more we can get comfortable doing that, the more quickly we can throw out the things that don't work so well and really focus on the things that are working well and leapfrog into progress.
Mm-hmm. Thanks. And Dr. Ostrovsky, why don't you close this out?
Sure, you bet. So I've suffered through founding a company that sells into the Medicaid space. And fortunately, we had great learning, had an opportunity to work with amazing people, and had a modest M&A activity out of it. What I would say is a lot of entrepreneurs will want to go after really exciting problems and really interesting and clever product solutions. And I honestly think that some of the most viable businesses in the Medicaid space actually go after the most boring or seemingly boring problems. And in the end, even a seemingly boring product approach, as long as it's helping consumers, that's all that really matters. And I think that a lot of us in the early stage technology startup space will think about, okay, how do we get to $1 billion valuation? How do we have hockey stick growth? And I would actually recommend have a look at how companies in the private equity backed space behave. And they tend to behave not looking at 100, 200, 1,000% growth year over year. They tend to think about steady year over year growth. And the way to get that is to build an actual business, generate actual revenue. And this comes back to a lot of these private equity backed companies are solving really boring problems. And they tend to be really esoteric and really technically wonky, but someone needs those problems solved. And I think that state Medicaid programs are some of the richest pools of solving what seem like boring problems, but are really worthwhile solving. The other thing I'll point out, there are so many incumbents in this space that are so slow to move, and they have a lot of money and they have really long contracts. And I would strongly encourage startups in the space, look at what problems those incumbents are solving. It's hard to guarantee anything, but I think there's a high pretest probability that those problems could be solved in much better ways. And I'm trying not to acknowledge the smirks amongst our Medicaid colleagues' faces, but like go in that direction, see what those boring problems are, look where the incumbents are, and then how can you do what they're doing, or how can you solve the problems they're trying to solve in a much more innovative, consumer-centric way. So I would just point that out. And then maybe I'll close with saying, I've alluded to state budgets multiple times. I think that is an inevitable reality that states are going to be in a really tough place for the next year and a half, maybe 2 years. And so we have to really think about, is this worth a state spending resources on? And so selling into a state may not be the best place to may not be the best beachhead customer, but I will share that in the past week, I've had 2 national payers share with me that, yikes, we have so much excess profit and we have not spent up to the MLR that we have to get cash out the door before the end of December. And so there's this really big push amongst multiple massive payers across the country to sign checks. I've had one portfolio company that went from demo to MSA in under 3 months, which is almost unheard of. So yes, definitely focus on the state, try to create value for the state, but keep in mind, like, states' budgets are going to be hurting way more than they usually are for the next while. And so health plans may be a more viable place to go. But again, don't lose sight of creating value for the state. I don't mean to say that, just it's important to think about sustainability and where revenue may come from. Thank you.
That is a very accurate understanding of where state budgets are right now. So thank you for that. And again, I want to thank all of the panelists. And if you have any questions for them, please feel free to use the Q&A function in Zoom. We do have just a couple extra minutes. And, you know, if you have any questions, please submit them there. We will now be going over into the presentations from the companies. Each company will be presenting for about 12 minutes, and with about 8 minutes after for some questions and answer period. So the Q&A will be from my colleagues and my fellow deputy directors, and we're very excited to hear from them. So I'll turn it back over to David.
Thank you all for your thoughtful comments on this really important issue. Really great discussion.